Back to the basics, accelerated atrioventricular rhythm. A 48-year-old male, post-PCI to LAD, he reports 2/10 chest pain, otherwise hemodynamically stable. His EKG demonstrates all of the following electrocardiographic phenomena or features except fusion, VA capture, AV dissociation, and ventricular escape. So the EKG shown here depicts or shows all the features of fusion, VA capture, AV dissociations, ventricular escape, except one of these. So to answer this immediately, you can quickly look at the EKG, and for the rhythm interpretation, you can tell that there's two population of beats. There are narrow beats, and there are two runs of wide beats. So we'll come to these beats in a second here. However, you can also tell that there's some Q waves in the anterior leads, and there's some residual ST segment elevation. These are suggestive that the patient has a recent acute myocardial infarction, which is pertinent here since the patient has stented LAD. So back to the rhythm now, where the question is based on. So these three beats are clearly sinus beats with narrow QRS complex. This is a P wave happening at a rate of about between 70 to 75 beats per minute. Let's say it's 73 beats per minute. So this P wave, P wave, P wave, P wave, and actually this is the next P wave here. So the next P wave happens at the same time where the narrow or sort of wide QRS complex, which is accelerated atrioventricular rhythm, starts. So this P wave cannot generate this QRS complex, so this is essentially AV dissociation. So there's AV dissociation. The next P wave most likely occurred here, and the other one most likely occurred here. However, at the last beat, you can tell there is a different morphology at the end of QRS complex, which we do not see it here, and we do not see it here. So that's most likely a retrograde P wave, and this means that VA capture occur in this last beat here. So the AV dissociation for these three beats, VA capture here, sinus rhythm here. However, this beat here looks different than this, and then the ventricular tachycardia or ventricular rhythm beat, and this is likely a ventricular fusion beat or fusion beat. First, the PR interval, you can see it's shorter than the other PR interval, and the QRS complex morphology, let me just clean this. The QRS complex morphology of this beat is different than this beat and then this beat. It's kind of in the middle. And you can, if you want to see this more clearly, you can tell in this beat here. So this is the native QRS complex beat, this is the fusion beat, and this is the accelerated atrioventricular rhythm. So this beat here represents fusion. Okay, so far we've seen fusion, we've seen AV dissociation, and we've seen VA capture. The other part of the question asks about ventricular escape, and the answer of this, what we see here is accelerated ventricular rhythm, which is these beats here actually started here, are typically an enhanced automaticity somewhere in the ventricle or in the Hesperkingi system, in the ventricular part of the Hesperkingi system, that as a part of the reperfusion arrhythmias in patients with acute myocardial infarction, and it's not due to underlying bradycardia, so where the escape rhythm is. So escape rhythm typically occurs when the patient has severe heart block or severe bradycardia for whatever reason, and then after that you'll have a long pause, and then the ventricle starts escaping at a slow rate after that. That's the ventricular escape rhythm. But what we see here is completely different. We see here is the ventricle, in fact, is competing at almost the same rate as a sinus rate, so about 70-75 beats per minute. So the ventricle is competing and is not escaping. So the this answer here is the correct answer. So there is no ventricular escape, but there is fusion, there is VA capture, and there is AV dissociation. I hope this helps, and thank you so much for your attention.